acromegaly. And if it is thyroid hormone secreting adenoma, thyrotoxicosis, similar if it is ACTH secreting adenoma, it can lead to the disease. There are few differential diagnoses, a very big list of the differential diagnoses, but we have compiled it to the main differentials. So some differentials are from the pituitary region. By itself, it may be pituitary macroadenoma, and the other one important is the craniopharyngioma. Craniopharyngioma is same like a brother of the pituitary adenoma, but it comes from different families for different cells. Similarly, Rathke cleft cysts, meningioma of this region, that is tuberculum semimeningioma and plenum sphenidae. And paracellular region, the region lying laterally to the pituitary, to the sella turcica. The paracellular lesions can be any regions of internal carotid artery or maybe the artery that is supplying the pituitary gland. It can also lead to the aneurysm which increases in size and can present like a pituitary tumor. Similarly, cavernous sinus masses, similarly chordoma, chondrosarcoma, and glioma of the optic chiasm. Now, when you come to know that the patient have symptoms of pituitary profile, how you evaluate the patient? So you start evaluating it. First of all, you make a clinical judgment that this is the case of pituitary. Then we want to know that whether it is hyper functioning pituitary tumor or whether it is non-functioning tumor. If it is clinically non-functioning, clinically non-functioning tumor will be those which have normal hormones or which have suppressed hormones. But they will be giving the signs symptoms of bitemporal hemanopsia, or they may also be giving the signs of compression of the pituitary gland, that is hypopituitarism. So you come to know that is a non-functioning adenoma. So what we do visual field testing by the confrontation method. We do confrontation method visual for the to check the vision. We also check the pituitary profile, and we do special MRI that is called MRI with pituitary protocol. And when these all things are makes diagnosis, then we proceed for the surgery. If it is a functioning adenoma, whether it is prolactinoma, growth hormone adenoma, or any type, then we do we start medical treatment. We send it to the medical department or endocrinology department, and we put the patient on the medical treatment. So treatment options are there are three medical treatment options. Medical treatment, first is the medical treatment. Open surgery previously, even nowadays, still this surgery has been done transcranially when we go into the pituitary fossa, and endoscopic transpyramidal surgery. So in medical treatment, medical treatment is for those tumors which are secretory. For dopamine tumors, we have drugs that is dopamine agonists, that is bromocriptine and cabergoline. For growth hormone tumors, which leads to the acromegaly, we have drugs that is octreotide and prednisolone. While for Cushing, we can give mifepristone and ketoconazole. Indication of the surgery for the non-functioning tumors, as they are non-functioning, they will increase in the size. They are necroadenomas, so surgery is the only option. But for the and surgery is indicated when there is visual deterioration, when the medical treatment failure happens, when pituitary apoplexy is there because it is an emergency then, and when there is hydrocephalus because the tumor goes beyond beyond into the third ventricle, starts blocking the foramen of Monro and leads to the hydrocephalus. For surgical treatment, I would like to invite the head of department, Dr. Subhan Gondal, to come and briefly give about the discussion about the surgical steps of the study. Thank you.
Bismillahirrahmanirrahim. Good morning and welcome to the CPC of Neurosurgery for the Family. Let's take a minute to reflect on this picture. These are two pictures, one from 10 years before and one 10 years after. What is the basic change between these two? We can appreciate that at least two people have lost their job in these two pictures. The one pilot of the helicopter, and the second one making the video. And maybe they had nothing to do other than this, they didn't upgrade themselves with time. So, with every passing day, whether we like it or not, in fact, this 2019 drone is now showing to be the decisive factor between the biggest war in the world right now. So, with the time, we need to upgrade ourselves. And other than just these two people, maybe the fuel economy and all of that industry has changed because the same drone is doing the function of a big helicopter on the videograph. So, whoever doesn't progress with time, doesn't change, doesn't acquire the skill, they lag behind. This is a single liner message for today. So let's come to the endoscopic transcontinental surgery. And here I think, because we had started this with the help of my colleague, Dr. Ashar, I would give him the privilege to start with the nasal phase of describing the surgery. Dr. Ashar, please.
Thank you, Dr. Subhan. As per the vision of our Worthy Vice Chancellor, Professor Mohammad Umar Saab, we are transforming from isolation to multidisciplinary, interdisciplinary, and transdisciplinary work. So that is a part of that. Now we are contributing with each other, with other departments, and to manage the patients in their best interest and to provide them with the best management possible with the minimum resources. And this is our aim. That is why we are